Good evening. Welcome to tonight's discussion titled Time-Based Coding. Very happy to have you here. My name is Brett Papke. I'm the Director of Eye Care Professional Services with Revolution EHR. I am honored to be able to lead this discussion tonight with my colleagues Julie Beecher and Tracy Steenis. Now, Julie and Tracy will be answering questions live through the questions area, the GoToWebinar panel, so please feel free to ask as we go. At the same time, please understand that the audience here will be pretty large, so we may not be able to get to every question live. But we promise to do our absolute best after the fact and answer any outstanding questions through email. So this session is being recorded. I know Tracy will be happy that I remembered to say that. So if you do have to drop off, we will be posting this to the knowledge base, and you'll probably receive a link through email in the next few days. Our goals tonight, they're threefold. We're going to provide a quick recap of the coding changes that are taking effect in 2021. We're going to discuss how Revolution EHR is going to assist and support you specifically as it relates to time-based coding. And then we will illustrate the associated concepts in Revolution EHR where possible. So as a means of introduction, and I assume this will be a recap for many, but if it's an introduction, a pure introduction, that's okay too. It just reinforces how good it is that we have the opportunity to talk about this tonight. But think back to November 2019. And you may or may not be aware of this, but modifications were introduced at that point to the Evaluation and Management Code Series. Remember, when we say Evaluation and Management Code Series, we're talking about those 99,000 series office visits. We are not talking about the general ophthalmological services, those 92,000 codes. That code set and the requirements around those stay exactly the same. But on the Evaluation and Management Coding front, the powers that be formally recognized back then that they were asking a lot of doctors in terms of documentation and coding. So these changes are aimed to decrease the burden that's associated with the traditional approach, decrease unnecessary documentation that was finding its way into medical records just to support certain coding levels, and even through all that, decrease the need for audits. These modifications set to take effect on January 1st next year, and they represent the first change to evaluation management coding in over 25 years. You know, if you've looked at those documentation guidelines for the E&M services, you know that it's like a 45-page document, and the date on it could be either 1995 or 97, depending on the version you're looking at. But that's how long it's been that the current process has been in place. Now, you know in the present day that when you choose a 99,000 series office visit, you do it based on one of two approaches. Most commonly, people are choosing approach A here, or utilizing approach A, and that is a consideration of case history, physical exam, and medical decision making. And we often refer to that as counting up the points or counting up the elements, because you look at a physical exam, for example, and you count up all the different elements that were addressed, and that translates to an overall level for the physical exam element of the exam or component of the exam. And then how case history, physical exam, and medical decision making all interrelate determines what the overall visit code is. The second approach is time, and that one's not talked about too much because it's only relevant when counseling and care coordination take up more than half of the office visit time. And you don't see that happen a lot in primary eye care settings, so that's why most of the time you're familiar with case history, physical exam, and medical decision making. Now, as we move forward into 2021, we talk about the changes. It's going to fundamentally change the way that we select our 99,000 series codes when we use them. We will use one of two approaches. You'll use medical decision-making by itself, or you will use something called total professional time, and we will define that fully as we go. Medical decision-making, you'll notice, has no relevance or no mention of case history and physical exam anymore. It's just the medical decision-making component on its own. And you know, if you've been familiar with medical decision-making, you've utilized it in the past, you're still going to be pretty comfortable with it. There's some changes to the descriptions of those codes in CPT 2021, but by and large, it's going to feel very similar. You'll note, though, because case history and physical exam are not there, that is not the AMA or CPT saying you don't need to do those things. It's simply saying that those elements or those components, case history and physical exam, they can be documented as medically necessary, and then your final code determination selection is going to be based on medical decision-making alone. So let's turn our attention to total professional time, since that is the newer idea or the new concept. And there'll naturally be a question that comes from that of, you know, how do we select a code based on time? Well, one of the first ideas is there's a different range of times that are that translate to code levels based on a new or established patient. So we built two tables to highlight that. One of the first things that you'll see here is that level 1 coding is not possible through time-based coding. On the new patient front, that's because the level 1 code is actually being deleted next year. It just won't even be available through CPT anymore. But on the established patient side, we know that the level 1 visit is often referred to as a nurse's visit, and that's because the doctor typically is not involved in that care at all. And as we move into talking about what total professional time is in a second, you're going to learn that it is only the time that the doctor is spending on care of the patient. So if the doctor's not involved, then there's no total professional time, and therefore there's no level 1 possible. As you move on to level 2, you'll see that there's a minimum time. So 15 on the new patient side, 10 on the established patient side, which begs the question, well, what if I provide, say, a visit that utilizes 5 minutes of total professional time? What code do I use there? And the answer would be you wouldn't be able to code that visit based on time. You'd have to turn your attention to medical decision making if you're going to stick within the 99,000 code series, or you'd have to consider a general ophthalmological service, one of those 92,000 series codes. Similarly, or on the other end of the spectrum, if we look at level 5, you'll see there's an upper end, 74 minutes on the new patient side, 54 on the established. And that's going to prompt the question of, well, what if my visit goes over that or over those limits? And the answer there is CPT added or will be adding a new prolonged services code next year of 99417. And that's going to account for 15-minute blocks of time over 74. Now, this could get a little bit confusing here, so bear with me. The physician fee schedule for Medicare came out a couple days ago. And even though CMS proposed to use 99417 in its earlier rulemaking process this year, in the final rule that came out a couple days ago, they decided that they didn't like the description of 99417 anymore and felt that it could be confusing to providers. So there actually is a different prolonged services code here if you're working with CMS versus private third-party payers. So I'll restate that and say if you're working with a Medicare patient and you need to account for an extra 15-minute block of time or more, then you're going to use G2212. If you're working with a private payer outside of Medicare, then we're actually going to kind of need to keep our ears to the ground as far as being providers and learn what the preferences are going to be, because there are those two possibilities. The fundamental ideas, though, are the same. Regardless of what code it is, it's going to account for 15-minute blocks of time over that upper limit. So as examples, let's say I'm working with a new patient and I provide a 70-minute visit, or excuse me, let me rephrase that and say a visit that utilizes 70 minutes of total professional time. Well, that would be 99205. That's a level 5 visit. But if my visit is 80 minutes of total professional time, I'm into that first 15-minute block of extra time. So as a result, I would code that as 99205 plus 1 unit of the prolonged services code. If I'm into, let's say, 100 minutes, now I'm into that second 15-minute block, so I can add 2 units of the prolonged services code. That idea and thinking works the same way on the established patient side, the only difference being that upper end time limit is less on the established. It's 54 instead of 74. So again, I assume that's a lot of information there, and if this is your first exposure to that, this could be a little bit confusing, but hopefully there's enough in there that makes sense to build on in the future. The next question is usually, okay, well, I get that. What is total professional time? So we pulled this definition directly from CPT because I think it's really important that we understand what time can be counted as total professional time. And it is both the face-to-face and non-face-to-face time personally spent by the physician and or other qualified healthcare professional on the day of the encounter. It includes time and activities that require the physician or other qualified healthcare professional, and does not include time and activities normally performed by clinical staff. And I wanted to put that in there verbatim because I think there's a natural tendency when you look at other qualified healthcare professional, and a lot of times we'll make the leap and say, well, that's my technician, so I can include that. That is not the case. Other qualified healthcare professional is actually an official term used for providers that don't fit the classification of physician, but are still licensed to provide services independently and bill for those services. So think about nurse practitioners, physician assistants, certified nurse midwives. Those types of providers would be other qualified healthcare professional. So when we think about how this applies in the eye care practice, it is most commonly going to be the time that the doctor spends on care of the patient on the day of the encounter. The bulleted list here, running down the bottom, are the types of things that can be included in total professional time. So you preparing to see the patient, reviewing pretest data, things like that, obtaining or reviewing separately obtained history, performing the exam itself, counseling the patient and their family, ordering medications, test procedures, referring and communicating with other healthcare professionals when it's not separately reported, documenting the information in the EHR, independently interpreting results when not separately reported. And that parenthetical is an important one. When we're talking about special testing, we'll try to go through an example of that in just a second to highlight what that means. And then finally, care coordination on the bottom. So let's look at an example. Let's say we have a new patient. The new patient walks in the door. They check in at the front desk, takes 5 minutes. The technician eventually takes them back. The pre-testing takes 10 minutes. The doctor, prior to going in the exam room, or even if they're in the exam room, they're reviewing the pre-test data. That takes 5 minutes. The examination of the patient, 20 minutes. And then the doctor transitions the patient to the optical staff for frame and lens selection. So we just threw some random times down here, and these are obviously random events as well. You could very likely say, well, why would a 99,000 series visit translate to a frame and lens selection? That's a little bit beyond the scope of the scenarios I tried to think through. I just wanted to provide some ideas of activities that would happen during the course of an encounter and assign some times to them to highlight the fact that there's really only 2 of these bullets that qualify as total professional time. That is the doctor's review of the pretest data and the doctor examining the patient. The time with the front office staff, the time with the technician, the time with the optician, that is not total professional time. So we would have an aggregate of 25 minutes here. We'd take that to our new patient chart. We'd see that would fit in right at the level 2. So this encounter would be coded as 99202, and you'll see that that has absolutely no relevance or bearing on tests that were done. Right? It has everything to do with the amount of time that the doctor spent on the care of the patient and nothing else. Example 2, a little bit more complicated, but we'll throw a little bit of a wrinkle into it to talk about what we talked about on that bulleted slide a few back. Here we have an established patient. They check in, again, 5 minutes, pre-testing 10 minutes. The doctor reviews pre-test data. The doctor examines the patient. Let's say that during the course of the exam, the doctor identifies a retinal lesion that warrants, in their opinion, OCT. So the doctor orders a retinal OCT. The technician performs that OCT, takes 5 minutes. The doctor then interprets the OCT and rightfully codes 92134 and adds it to the claim. And that process takes 2 minutes. At the end of the visit, the doctor writes a letter to the primary care physician and summarizes her findings and summarizes what she plans to do about it. And that takes 5 minutes. So the key part of this is understanding that the OCT being coded separately includes the interpretation report. We know per CPT that the description of OCTs and many of the special tests that we order contains reference to interpretation report. Said differently, performing the interpretation report when I code for that procedure is part of that code and not part of the time that I would track for the office visit itself. That's why you're not seeing the doctor's interpretation of the OCT and seeing those 2 minutes included in total professional time here. But the letter to the primary care physician at 5 minutes, that would be included, again, because it's either face-to-face or non-face-to-face time that the doctor is spending on care of the patient that same day. So here we're looking at 25 minutes. We take that to our established patient chart. That fits right in this 20 to 29 minute range, which would equate to a level 3 office visit. So again, very similar to the time intervals we talked about, these concepts, hopefully they make a little bit of sense at their foundation that we can continue to build on as we talk about it more in the future. With those ideas behind us, though, as foundation, let's talk about how Rev's going to help you here, because with new rules, there are new things that we need to consider to empower you to take advantage of these new rules. So 3 new tools are coming your way. One is an encounter timer. Obviously, if there's going to be time-based coding, we want to make it real easy for you to track time. Secondly, if the rules of coding are changing, then our approach to the auto-coding system needs to change, and we need to build into that consideration of time. We don't want you to have to look back at those tables we looked at in the beginning. Why can't the system present that information to you? We believe it can. And then finally, total professional timestamp. As you think about this, and we'll talk about this more in a second, the audits of the future are going to change significantly in how an auditor will actually validate that the code that you used matches or is appropriate for that encounter. So when we code based on time, we're going to need to have documentation of that. We're going to make it easy to provide that information on your encounter printouts that might be provided in the case of an audit. But we'll talk through each of these ideas, and we'll start with the idea of the encounter timer. I mentioned we'll be adding a timer feature that's going to allow you to track total professional time, and you're going to find that right in the header of the encounter. You'll see there's a start and stop button. You'll also see there's 2 times here. We would define this first one. I would encourage you to think about it as the session timer, whereas the total would represent the total professional time or the aggregated time of all sessions that you may spend with a patient. Now, most commonly, these 2 numbers will be the same, but let's go through a scenario where they'd be different. Let's say I work with a patient for 15 minutes. They then have their eyes dilated, and I say, well, I'll see you back in a little bit. Or I'd probably phrase it more politely and professionally than that, but I think you get the idea. And I log out of Revolution EHR, and then I come back later and I log back in. Now, when I open that patient's record again, the total time will still show me the 15 minutes that I spent originally. But because this is a new session, this timer would be back to 0. And we built it that way because some people may choose to use this system outside of coding. They may choose it to start studying the amount of time that various aspects of their encounters take. So there's that much flexibility built into the way the system works. But ultimately, you can start and stop this timer as many times as you'd like. The next bullet says you also have the ability to manually adjust time. So if I was to click the total professional time, okay, that will actually serve as a link. It will open this adjust time modal. And through this modal, I'll be able to add time in to account for time that I've spent outside of an encounter. So maybe my review of pretest data or writing a letter is something that I don't want to use the quote unquote stopwatch for. So in that case, maybe I would just open this modal up and add 5 minutes. Any reason that I add here, by the way, would appear in the audit log if I ever reviewed the audit log, as we should be doing as part of our normal security processes periodically. But that's where that reason would show up. This mode will also allow for subtraction of time in the event of an error. So if I tried to add 5 minutes and I added 55, there needs to be a way for me to remove that extra 50 minutes. And I can do that by adding minus 50. And it'll update the total time appropriately for me. The other thing that this modal will allow me to do is track time externally and then still use the other features. And by that, I'm trying to say, maybe I want to use my watch, or I want to use a clock on the wall, or even the system time on my computer rather than the timer system in Revolution. If I wanted to do that, I could open this adjust time modal at the end of a visit and just plug in the total professional time here, and the system will log it for me. And then that would allow me to leverage the auto coding system to have it converted to an office visit code for me. It would also allow the documentation on the encounter PDF to happen automatically for me. But again, just another sign of the flexibility that we're trying to consider and consider the various workflows that people may follow. A final idea on flexibility is this timer feature is going to be both preference and permission based. And that is to say, on the preference side, if you don't think you're ever going to code by time, you can shut this off. So these things don't appear here and they would never distract you in any way if you felt that they were that way. On the flip side, if you think you may use them from time to time, then you can leave them on. And from a permission standpoint, you'll be able to control who can interact with these and who can use them. You'll do that based on user role. And our recommendation would be that only the providers and potentially scribes would be allowed to use the timer feature. That's because those would be the 2 roles that would have direct knowledge of the total professional time, right? The optician, the front office team, the technician, those people don't have direct knowledge of when the doctor is working with the patient. So if we're using this from a total professional time from a coding perspective, it's really the doctor and potentially the scribe that should be included. Now, again, feel free to use the system however you'd like, but if you're using it from a total professional time perspective, those would be our recommendations. Now, as we talk about timers, there's naturally going to be some questions about, well, what if I forget? What if I forget to stop the timer? We're going to automatically stop it in a number of scenarios for you. One, this isn't really automatic, but if you manually stop the timer by the stop icon, it should make sense that Revolution EHR will stop the timer for you. But if you forget to do it that way, the events listed below that will automatically stop it for you. So you close the encounter tab, you close the patient record or file, you close the browser tab, you log out of Revolution. Maybe the system is locked because you decide to step out of the room for a minute, but you know you're going to jump back in and jump right back into the record. And you don't want the patient and patient family to be able to see the Revolution EHR screen. That would be another event that would stop the timer for you. And also, if you sign the encounter, that would stop the timer. If something happens where you left the timer running, maybe the encounter is over, the timer is running, and you decide to walk the patient out to the front office, and you fully intended to go back and stop the timer, but you forgot to do it, and you went off and you did something else. And that instance of Revolution is staying open and the timer is running. The adjust time modal that we just talked about would still allow you to back out any extra time that you inadvertently added in through forgetfulness or any other reason. So there are those safety nets as well that we tried to build into the system to protect you as much as possible. Tool number 2, time-based auto coding. Remember, in the present day, we talked about the fact that the coding rules have us considering case history, physical exam, and medical decision-making. And in the future, it's just going to be medical decision-making and time by themselves. So we need to modify the auto-coding system to help you on that front. And what you're seeing here in this modal, and I should back up a second and say, many of you will know that on the coding screen with an encounter, you have 2 buttons. One says Code Exam. The other says Auto Code Preview. Now, when I select Auto Code Preview, this modal down here is going to open up, and it will present me with both the total professional time and medical decision making when they are both available. That is to say, if I do not use the timer in any way, shape, or form, then I won't see any sort of code suggested to me over here on the professional time side. Similarly, if I don't use the medical decision making screen, I won't see this stuff over here. But if I use both features, both the timer and the medical decision making screen, then this becomes a really powerful tool for me because it will show me the potential code via each approach. And this allows me to do certain aspects of strategic coding and making decisions about selecting the code that's going to reimburse me better. In this scenario, I can see that the encounter qualified for level 2 based on time, level 3 based on medical decision making. So if I wanted to be reimbursed at the best level for this visit, I could accept the medical decision making based codes. Now, Code Exam, in the present day, simply applies the applicable code to the encounter. And it's going to continue to do that in certain scenarios. For example, if you only use one of these approaches and there's only one possible code, it'll put that code on there for you. And if you use both approaches and the code is the same, then it'll apply the code. But what we didn't want to do is assume in a scenario like this that you're always going to want the higher code. We didn't want to make that assumption on your behalf. So in instances where the code is different, using the Code Exam button will present this window for you and let you know that there's a difference and actually give you the ability to make the decision about which one you'd like to use. Finally, a total professional timestamp. We talked about audits, or I very briefly referenced them earlier. The idea here is that audits of the future are going to look a whole lot different because in the present day, if anybody's gone through one, you know that a third party sends you a letter or an email, however it may work, and they say, I'd like to see these 10 records. Please send them, please print them out and send them to us, fax them to us, or securely upload them to this portal. We'll provide you the address. And then what happens is an auditor sits down at a desk, goes through your record, counts up all the elements of the case history, physical exam, medical decision making. They then code the encounter and compare it to the code that you selected at the time that you submitted the claim to be reimbursed for care. If those two match, great. If they don't match, then that's what potentially creates problems. When we talk about time, how would an auditor be able to verify that the time that you've selected equals the appropriate code that you've selected? I think I worded that improperly. I should have said the time. How would the auditor know the amount of time unless you've actually documented in the document that you've submitted? Okay, so we're going to provide you the total professional time in 2 places. One, will maintain it in the header for you, and that is to plan for an instance of an in-office type of audit, as well as support people who are using this more for analytical purposes and they want to see how long this encounter took. So that's one place it'll appear, and the other will be in the PDF view of an encounter. Typically, these are what are provided to audit teams to verify that the final code was selected appropriately. So we will provide that total professional time on the PDF automatically for you. Now we've also made this timestamp preference based, meaning you can turn it on and off at your discretion. It will be off by default because we would assume in most cases, we know doctors are trading these informations back and forth, or they're sending them to consultants for certain cases, and you may or may not want the total professional time displayed on there. Since it's not really relevant in those consulting types of scenarios or referral scenarios, we had made the assumption that you probably won't want that on there. So we set the default to no. You can certainly change it to on. But if you leave it off and an audit came your way and asked for 10 records and you've identified that a certain subset or all of them were coded based on time, then you could temporarily turn that preference on, print out those 10 encounters, and it will have the total professional time listed there, and then turn the preference back off so the total professional time disappears from each subsequent print. So said differently, the preference will allow you just to turn it on for audits and turn it back off if that's the procedure that you choose to follow. So let's summarize all that. Valuation management coding is changing January 1st, 2021. Remember, those are your 99,000 series office visits. If you joined us late, this does not impact general ophthalmological services, those 92,000s. When we think about how E&M coding is going to work next year, it's going to depend on either professional time or medical decision-making alone. Remember what we said before is that the AMA is not saying that case history and physical exam are not important. Those are still things we should be doing as part of our day-to-day lives, but they will not be relevant when it comes to final determination of office visit code. Medical decision-making guidance is very similar to what it's been in the past. They've cleaned up the descriptions a little bit to make it a little bit easier to decipher. But if it's something that you've been comfortable with in the past, you're going to continue to be comfortable with it moving forward. Time-based coding, on the other hand, is really a new concept, and we defined it as consideration of all time the doctor spends on management of the case on the day of the visit, unless it's included in the other codes that the doctor may put on the claim. We talked about a scenario where an OCT was performed, so the doctor included 92134 on the claim, and because of that, the time spent on the interpretation report for that OCT was actually included in the 92134 code and not the office visit. To help you, Revolution EHR is going to be adding 3 tools in January, and we talk through those: the encounter timer, time-based auto coding, and the total professional timestamp on encounter PDFs. I'll make one other point on this screen as well, because it will probably come up in questions, because we know it came up a number of times in the questions from the session earlier today. And the questions are typically phrased something like this. Do I need to pick MDM or time at the beginning of the year? Do I need to practice the same way throughout the year? Can I pick and choose which approach to use on a case-by-case basis? Which approach should I use? And what we would recommend is that you develop familiarity with both medical decision-making and time-based coding, because there definitely will be scenarios where one supports a higher code than the other. Beyond that, get comfortable, if you're not already, with the requirements of those 92,000s, because you are in a very strong position if you understand 92,000s and the MDM and time-based approaches to evaluation and management coding, because then you will understand that you have often many options when it comes to coding an encounter, and you can often make those decisions based on the method that will end up reimbursing you most properly for the time that you're spending. So I hope that was a fair summary of things, and I hope it brought to light some ideas that might be new. Very happy to look through questions that Tracy and Julie might have been answering throughout. I will say this in case I don't get the chance to do it later. If you have questions outside of this session, maybe you're watching in recorded format, revassure@revolutionehr.com is one way to get email questions to our team. The other is the Ask Revassure link through the help menu in Revolution. As I said, both of those come to the documentation and coding team at Revolution EHR. We will do our absolute best to try to get you answers to those questions the very same business day. So with that, I will say thank you and turn it over to Tracy, and we'll see what questions they might have been addressing in the popular ones that were out there.
Thanks, Brett. First, thank you for reminding everybody that this is being recorded, and we will upload a recording. In addition to that, in the knowledge base with the recorded version of the webinar, we will have Brett's slide deck as well. So that's always exciting. Just a couple of questions, I think, unless they come flooding in as soon as I say that. So I used to have a tech, but now I do the fields and the OCTs myself. How does that relate as far as how?
Yeah. Yeah, it depends on how those end up being coded. Okay, so if you, as the doctor, are performing the OCT or the visual field or photos, whatever it may be, if you're going to code for those procedures, the time spent on the interpretation report of those is actually included in the code that you would be sending to the insurer to be paid. So that's the idea behind it. Now, if for some reason you didn't code for those procedures, let's say in the OCT scenario that I used, I didn't code 92134. So I identified a retinal lesion that I wanted to scan. I scanned it myself and I didn't code for 92134. Then the time that was actually spent on the OCT and the interpretation report could actually be included in my total professional time, if that makes sense.
Perfect. Thank you. Here's one. I'll put you on the spot. I've heard that auto coding triggers problems in audits. Is this true or is it no longer true?
I'm not familiar with that. What I will say is this, that auto-coding systems really are looking at documentation. So if your documentation reflects, and accurately does so, reflects what was done during the course of an encounter, and what was done during the course of the encounter is what you deem necessary to care for the patient on that day, then there's absolutely no problem. Now, a dovetail to that is if everything is documented in the record simply to fill up the fields, whether those procedures were done or not, then auto coding is obviously going to raise the level of coding for that visit. And that's where I think problems can come in sometimes. We see that happen a lot of times with pull forward types of features where information is indiscriminately pulled forward, whether it's been done or not. And honestly, that's one of the reasons why these code changes are being made. They know that that happens, and they're not faulting anybody. They're just understanding that people were trying to get to certain coding levels by documenting certain things. So the belief is by making the final code determination a little bit easier, then it reduces some of that burden on us as providers as far as our documentation goes. I think I went far beyond the scope of that question, but there's a
That's
couple
okay.
different perspectives and angles on auto coding. The ultimate of it is if your documentation is accurately reflecting what was done based on the patient's needs or your needs that day, then the auto coding system is going to be great for you.
Perfect. Yeah, kind of a two-parter from a doctor. So I'm going to try and blend these together. Would you be able to add in time spent before an encounter, like prepping the day before, or add in time spent after you sign the encounter? For example, working with a pharmacy on prior auths for a med that's prescribed.
On the first part of the question, you can most certainly add in time that happens prior to an encounter. However, the encounter probably has not been started yet. Okay, so as a
Right.
result, that may be something that you need to mentally make a note of and say, yeah, well, I spent 5 minutes this morning going over this patient's information, so I'm going to use the adjust time modal to add in those 5 minutes. Now, you did mention the day before there, Tracy. And
Hmm.
remember back on our definition slide of what total professional time is, it is time spent on the same day as the encounter. Okay, so something happening or taking place on a different day wouldn't fall within the realm of total professional time. As far as what happens after the visit, as long as it is same business day and it is, same day of service, get my terminology messed up, and I'm doing something that is pertaining to the care of that patient, then that is time that can be tracked and added in as far as total professional time goes.
That ties into the next question, actually. So I'm going to just make sure that that it applies. Someone was asking, what if you're evaluating your records, previously diagnosed glaucoma patient the next day, and you're finishing your coding and charting the next day?
Yeah, there are, and unfortunately, I don't have a really good handle on the outside of the same business day prolonged services codes. There are other codes that exist to account for services that happen outside of the same day. But here's what I can say as a general statement about those other codes is they typically have a minimum time requirement, and that minimum time requirement is around 30 minutes. Okay, so if you don't spend at least 30 minutes going over that stuff, either the day before or after or subsequent days, whatever it may be, those codes wouldn't be possible. Yeah, so that's how I'd answer that.
Great. Can you give us a reminder for both the doctor and staff? Where there are resources to learn or understand how to answer those MDM questions.
Sure. MDM, as our medical decision-making component, is we have a medical decision-making screen, first and foremost, in Revolution EHR. That has been there by default. You'll typically find it within the assessment plan step of an encounter. If it is not there, it may mean that you removed it at some point in time. But the reason I'm bringing it up is because you'll notice that the three related fields within the medical decision-making screen have question marks at the far right of them. Those question marks link to an area on our website that will describe each of the three components of medical decision making and how you make determinations at the various levels there. I was appropriately reprimanded in the earlier session by pointing people to a reference that we had within our help menu of the past that referenced the documentation guidelines. And you can still find those documentation guidelines out in the real world. We took them out of the help menu simply because they are no longer going to be relevant as far as coding goes as we move into the next couple of weeks and we hit January of 2021. So long-winded answer there, but the answer is you can get to resources directly out of Revolution on the MDM screen by using that question mark that's there. We will also be posting updated information in the knowledge base to update everyone on the description changes to medical decision making.
Great. I think we've answered this a couple different ways, but it's come up a few times, so I'm going to ask it one more time. What if the doctor does all the pre-testing?
Yep. That is total professional time, right? It's not necessarily the activity, it is the person that's doing them. Okay, so if the doctor is involved with doing stuff that is involved in the care of the patient, then that is total professional time. So if you are doing the pre-testing, if you're running your own diagnostic testing, and you're not coding for those extra diagnostic tests, those are all elements that can be included in total professional time.
Here's one we don't get in Wisconsin a lot, but exams take more time when non-English speaking patients use an interpreter. Does that need to be mentioned in the exam, kind of accounting for the time?
That's a really good point. I've seen it mentioned before, and I would just be, I don't want to give inaccurate information. So I would like to actually address that question outside of this as I have the chance to check the resources, if that's
That
okay.
sounds great. Yeah, yeah. And for anybody that if you know your question's not being addressed, your names are coming along with this, and we will review these afterwards. Um, sorry about that. I am just going through. Uh,
As you talk through that, Tracy, let me give an
yeah,
example because
thank
I
you.
know we did this earlier. I mentioned on the summary slide that there are definitely going to be scenarios that you encounter where MDM produces a higher code than time or vice versa. So think about a scenario like this, just as a an example. Say you have a patient with two stable chronic illnesses. Maybe they have well-controlled glaucoma and maybe mild macular degeneration, that these conditions haven't changed for multiple years, so you're considering them stable chronic illnesses. And maybe your most recent encounter with that patient utilized, let's say, 25 minutes of total professional time. That 25 minutes of total professional time would qualify for a level 3 office visit. Whereas just by the virtue of having two or more stable chronic illnesses, it is very likely that that encounter is going to qualify for a level 4 visit based on a moderate level of medical decision making. Now, that's kind of a blanket statement on MDM, and there are other considerations need to go in there. But in general, that's kind of where that patient would fall that has those two or more stable chronic illnesses. Conversely, you could have a situation where maybe you saw a patient last year that had cataracts, and you said, let's see you next year. Let's just make sure these things aren't progressing at a significant rate, aren't impacting your ability to see, make sure everything stays healthy. We'll call that one stable chronic illness. Okay? And through medical decision making, that would be a level 3 visit. But let's say it was one of those patients that just takes a long time. They take a long time to respond to questions. Whatever it may be, the encounter just takes a long time. And maybe it takes 35 minutes. By time, that's a level 4. By MDM, that's a level 3. So that's where I was getting to on that summary slide, where I said there are definitely going to be scenarios where these codes won't be equal between an MDM and time-based approach. So putting yourself in a position of understanding both of them and when to use them and when not to use them can actually go a long way towards helping in terms of practice reimbursement.
That's a perfect lead into a question that just popped up because somebody said, if I don't finish coding assessment plan the same day as the encounter, I can still use MDM for coding. So it
Mhm.
sounds like you're saying you can, but you might might benefit from time. It just depends, right?
Yep. Yeah, and it may be a trial and error process to see how
Hmm.
things work out in those scenarios. It might be interesting as you get working on this to send a question and talk about what you're experiencing, some of the challenges you're running into, and we can talk through them and see what if there are any possible ways to overcome any challenges that you're experiencing.
So I think I have one last question for you, Brett, and then we'll let everybody get on with their evening. If you're trying to complete a chart before the patient leaves, but you're still planning on writing a letter, can you just adjust 5 minutes or whatever you think for your average letter writing time so you can complete
Mhm.
and sign the chart even though you're writing the letter later?
Yeah, I think the answer to that is going to come down to everybody's comfort level. And from a personal standpoint, I see absolutely no problems with that at all. I mean, you are working within the confines of the rule. As long as that letter is being written the same business day, you know that typically takes you 5 minutes. There's going to be absolutely nothing wrong with that. Similarly, you could say the same on pretest data review. If you know that that's going to take you X amount of time, adding that time in probably isn't going to create any issues. But again, it comes back to each individual clinician, each individual provider, and what they are comfortable with and how they're comfortable proceeding with this.
And I promise that was the last one, but this is a really good one that just came in. So one more. Do we need to, or should we indicate on the record which method of coding we used for that encounter? Do we have to state that someplace?
There are no formal regulations around it right now saying that you must. I think it's a potentially good approach. What we said in the earlier session, though, is it could get into a challenge of, is it creating burden for you? If the answer is no, and you don't see that as a big deal, then, it's another step towards making it absolutely clear what you did in your record. If you don't put that information there, the worst thing that can happen is an auditor would actually ask you what approach you used. And they may not even ask you at all if time-based was the approach that was used, and that time is reflected through the printout on the PDF that we mentioned, and it jives with the code you use. So long-winded answer again of saying, if you want to put that information there about the approach that you used, it's probably an okay thing to do, and it's another step that you're taking in making sure that it's clear to any third party how you coded it. But at the same time, I don't think it's 100% an absolute must at this point in time until we hear otherwise.
Wonderful. And not a question, just a comment. Thank you for a great webinar, Brett.
Awesome.
Very informative. Yeah. And again, if I missed one of your questions, we'll review these after. So thanks, Brett.
Yeah, absolutely. Thank you, Tracy. Thank you, Julie. Thanks, everyone, for attending. I hope this was helpful. Again, if you do have questions, please let us know through the avenues listed here on the screen. With that, we'll sign off, say I hope you have a great evening. We'll talk to you again soon. Good night.